All right, let's talk about something you're absolutely going to see if you're managing lung transplant recipients, cytomegalovirus. We just call it CMV. It's honestly one of the biggest challenges we face with these patients, a real hidden threat lurking after surgery.
So, imagine this. You've got a patient, they're about 40 days out from their lung transplant. Things have been going pretty well. But then they spike a fever, they've got this new cough, and when you check their numbers, their lung function is heading in the wrong direction. It's a classic story, and you've got to act fast.
So what's the first thing that flashes through your mind? The big one, right? Is the body rejecting the new lung? Or could this be something else? This is the crossroads you're at, and figuring out which path to take is just critical.
To even begin to answer that question, we first need to get a handle on our enemy. And that means understanding this really fundamental idea, the difference between just having a CMV infection versus having CMV disease. They are not the same thing.
Okay, so let's lock in our definitions. CMV infection, this just means the virus is there. We can find its DNA in the blood and the tissue somewhere. But here's the key. The patient might feel totally fine. No symptoms at all. The virus is present, but it's quiet. For now.
Now, CMV disease, that's a whole different ballgame. This is when that quiet virus wakes up and starts causing problems. We're talking symptoms you can point to, like a fever or just feeling awful. Or even worse, it becomes tissue invasive, meaning it's actively attacking an organ.
Let's just look at this side by side because it makes it super clear. Infection. Virus is there, patient's probably asymptomatic, and we might just pick it up on a routine screen. Disease. Virus is there, and it's making the patient sick. You need to make a clinical diagnosis, and, this is the big one, you have to treat it. Getting this distinction right changes your entire management plan.
So, what does CMV disease actually look like? Well, it's a whole spectrum. It could be as subtle as just finding the virus in the blood without any symptoms, or it could be a full-blown CMV syndrome with fever and a low white count. But the one we really truly worry about in lung transplant patients is tissue-invasive disease in the new lung. We call that CMV pneumonitis.
So back to our patient. We suspect they have active CMV disease. How do we prove it? Let's open up the clinical toolkit and see what we've got.
And this quote right here just hits the nail on the head. It says that CMV pneumonitis and acute rejection can look almost identical. The symptoms, the drop in lung function, they overlap. That's why being sloppy isn't an option. We have to be methodical.
And here is that methodical approach. This is the playbook. It all starts with your clinical suspicion. Then you order a quantitative PCR test on the blood to see how much virus is floating around. But to really know what's happening in the lung, you've got to go look. That means a bronchoscopy to wash out some cells, a BAL. And for the final definitive answer, the gold standard, a transbronchial biopsy. We need to see the virus in the lung tissue itself.
Okay, so we did the workup, the biopsy comes back positive. It's CMV disease. Time for the counterattack. Let's talk treatment.
Our main weapons are antiviral drugs, and we pick our weapon based on how sick the patient is. For milder cases, like a simple CMV syndrome, we can often get away with an oral drug called valganciclovir. But for the serious stuff, for CMV pneumonitis, we don't mess around. We go straight to IV ganciclovir to make sure we get maximum drug levels into the system right now.
But here's the thing. Killing the virus is only half the job. We have to do this really delicate dance, this balancing act. We need to carefully, cautiously lower the patient's immunosuppression. We're basically taking the brakes off their own immune system just enough so it can wake up and help us fight the CMV.
So let's say we do all that, and the patient gets better. The infection is treated. We won, right? Well, not exactly. The fight isn't over. We have to talk about the long-term risks and the battle after the war.
Just look at this number for a second. 2.19, that's the hazard ratio. In plain English, it means that having even one episode of CMV pneumonitis more than doubles a patient's risk of developing chronic rejection down the line. It's a huge blow to the long-term health of that new lung.
And if that number doesn't hit home, this chart will. It's about 5 years survival. For patients who never get CMV pneumonitis, it's about 71%. But for those who do, it drops all the way down to 53%. This complication is, without a doubt, a killer.
So let's throw another wrench in the works. Imagine you're 2 weeks into IV ganciclovir. You're doing everything by the book, but you check the labs and the viral load, it's not going down. It's actually still going up. Now what do you do?
This is the moment you have to start thinking about antiviral resistance. Your playbook is to first send off a blood sample for genotypic testing to look for specific mutations. While you wait for that, you see if you can safely reduce the immunosuppression even more. And then you've got to switch drugs, usually to something like foscarnet, which works in a different way.
Which really brings us to the big, final question we should all be asking ourselves. Is CMV just some acute infection we treat and then move on from? Or is it something more, like a lifelong partner in managing that transplant, something that's always there, influencing the outcome? All the evidence tells us it's definitely the second one.